Thank you, doctor. There was some disturbance. I will. Thank
Neha.
you. Dr. Neelam, please. Dr. Neha. I'm sorry.
A very good morning, good afternoon to all. I would like thank you AIS committee to allow me to speak on this topic. I would not be speaking of the parameters about Pentacam. I would just directly jump to how to like clinically interpret in case scenario basis. Okay, because sir has already explained them in depth. So when we look at a pentacam map, so what all four things you have to see. First to see is the symmetry. Symmetry, like what is the bow tie pattern, is it symmetrical, asymmetrical, is there is any skewing. Then you have to see is there any steepness present, how is the pachymetry, and we have to compare the map with the other eye. So first is symmetry. The guideline for symmetry is that the inferior superior asymmetry, if it is more than 1.4, then it is abnormal. Asymmetric bow tie is pattern is present. Skewing of the axis more than 21 degrees is present. So here is a map where you can see that there is inferior steepening is present and some sort of thinning is present. And this is correlated. The steepening and thinning is exactly correlated with the elevation maps anterior and the posterior. So here we have to see the steepness, pachymetry, and so we can conclude that this is a case of keratoconus. The other thing that you have to see is that you have to compare the other eye. Like this is most important when you see cases like form first keratoconus. There will be no slit lamp finding. The abnormal topography will be there. So when you see, there will be asymmetrical pattern. One eye, you can see that inferior symmetrical pattern is there, and the other eye, absolute normal cornea you can see. So this case is form first keratoconus. So example, this is a case where inferior steepening is present, some sort of thinning is present, and anterior elevation and posterior elevation cutoff values like more than 12 and more than 18 on the posterior elevation is there. So this is definitely keratoconus. Another map where this is an op-scan map where in the inferior, there is no typical pattern that you can see, but there is some sort of thinning. But the 3 mm zone irregularity, 5 mm zone irregularity is not there, it is exactly normal. So this case is just a thin cornea and not a case of keratoconus. So now coming to the other example, here you can see that there is a bow tie pattern is present, and when you see the pachy map, there is some sort of thinning present. But when you see the anterior elevation looks normal, but the thinning which is present at the apical thinning that you can see the thinnest location, that is around 490, and the thinning corroborates exactly with the posterior elevation point. So this is not normal. These cases should not be taken for refractive surgery. These are high risk factors. Another example is here you can see that this map, in the sagittal map, what you can see, there is a bow tie pattern. The bow tie pattern and some sort of thinning is present, but the anterior and posterior elevation is normal. So what do you think, this is keratoconus or not? Then what you have to see is that you have to compare it with the other eye as well. Here what you see is it is exactly mirror image of the right eye. Both bow tie patterns are like mirror imaging, and this is definitely not keratoconus. The other example is that here you can see there is some sort of inferior steepening is present and thinning is also present. So here would you go ahead do a refractive procedure? Definitely no, because cornea is way beyond, like less than 500 microns, and inferior steepening is present. Then you see the other eye as well. Then what do? You compare it with the other eye. Other eye also shows some sort of inferior thinning. You definitely will not proceed with a refractive procedure, but what you will do is keep the patient on a follow-up, regular follow-up. So on follow-up also, the patient had maintained same type of keratometry findings, but there was no, like this patient cannot be undertaken for refractive procedure. Here another example is where some sort of steepening is present. Steepening is present and thinning is present, but the anterior and posterior elevation are absolutely normal. So this is not keratoconus. But when you see, compare it with the other eye, what you see is there is some sort of superior steepening is present. Superior steepening, and because of this patient again cannot be taken for a refractive procedure. Another example is like here you see some sort of steepening, but the corneal thickness is absolutely normal. The anterior posterior elevation is normal. Then you have to compare it with the other eye. The other eye looks absolutely normal. So here what is the problem? The problem is not there exactly. Like here you have to see the astigmatism as well. Here in the right eye, what I had shown is that the astigmatism is less than 0.5. So all the rules that are the cutoff values to take the patient for refractive surgery do not apply, because the astigmatism is less than 0.5 and this patient can be safely taken for refractive procedure. Another example being, here there is no no classical pattern can be seen. Corneal thickness is normal and the elevation points are also look normal. You compare, looks like fine, that the cornea is fine. Then you compare it with the other eye. Other eye also looks the similar pattern, like no classical pattern, thickness is normal. So this patient can be taken up for refractive procedure. Another example is like here, what you see is there is the symmetric bow tie pattern is present, but cornea is somewhat steep. Corneal thickness is normal, the anterior posterior elevations are normal, and but this eye is absolutely normal because there is the symmetrical bow tie is present, but it is a steep cornea, but it is normal eye. And the other eye has also the same finding, so this is just a steep cornea and not keratoconus. See, another example here, what you see is that there is inferior steepening, but the inferior steepening is not related, the thickness thinning, the minimum thickness is not at the correlation of the steepness, it is somewhere else. So this is not keratoconus, this is an eye like the post-peak scar. So thinning is present at somewhat temporal region. So you have to know from where you have taken the, this is important, from where you have taken the scan. Sometimes it can be misleading. Another example is like here you are seeing a scan of OpScan where inferior steepening is present, but thinning is seen in the superior side. So this is also not correlating. And when you see the other eye also, the inferior steepening is present and thinning again is not correlating to that point. So what is it? It is very important to see the patient again clinically, examine the patient clinically. So this patient had SPKs present post-viral conjunctivitis. So we had started treatment for viral conjunctivitis and the patient's symptoms had improved and the findings that were seen on the OpScan significantly improved. Another example being, here again some steepening is present. Cornea is minimally thin, but it is correlating with the steepening. And when you see the anterior and posterior elevation, it is beyond the normal values. So this is also a high risk case and should not be taken for refractive procedure.
Can you conclude, doctor, please?
Okay. So this for here what you can see, I'll just take 1 minute. Here this is, what do you see? Do you think that these scans are of keratoconus? No, like you have to see, correlate the patients with clinically examining the patient. This is like scar patients after corneal tear repair. So steepening can be seen in all these cases. So corneal conditions like pellucid marginal degeneration, there will be crab claw-like appearance and like this sagging kind of against the rule astigmatism can be seen. Some patients you have to see them carefully because they look just like against the rule astigmatism, and you have to see the other eye scan also, so that you should not miss the pellucid marginal degeneration and proceed with a refractive procedure. Then in Turrian marginal degeneration, you will be seeing again against the rule astigmatism. In keratoglobus, generalized thinning will be seen, and then this is a case of like where there is DM split. Here what you see is that the cornea is like thicker, but there is thin steepness is very high. So this occurs in cases of where there is DM split. So I'll just move on to the red flags. Red flags in Pentacam are like first there will be you have to see the keratometry findings that Kmax should not be more than 49. Then what you should see is that the inferior irregularity or steepening is present and it is not normal. Then anterior elevation should not be more than 12. Posterior elevation should not be more than 18. And that all these things like anterior elevation point, posterior elevation and the pachy, all the points should be coincident. And then the bad maps, you have to see the color coding in that, like after the difference map, what you have to see is the red indicates that it is not normal and yellow indicates it is suspicious. And the abnormal corneal thickness spatial profile and percentage thickness profile. And D value should not be more than 1.6. Thank you.
Nice presentation, Dr. Neha.